This presentation was created by Dr. Donald Jurovich, a professor of geriatrics at the University of North Dakota. Today's presentation will cover the topic of urinary incontinence. The goals for today are to look at the prevalence and impact of urinary incontinence in the older adult population. We'd like to talk about the risk factors, do a little exploration of the pathophysiology of the different types of urinary incontinence, and then get into the meat and potatoes of how we evaluate and treat it. Firstly, we have to have a common definition. We can consider urinary incontinence as any involuntary leakage of urine, regardless of etiology. Excitement could be a reason for involuntary leakage. There are 4 types of classification: urge, stress, mixed, and obstructive incontinence. We want to talk about the differences, how they're represented, and the mixed versions of that. With age-dependent changes, we always need to distinguish between that and disease in late life. There are some normal aging processes. Here you can see a graph that demonstrates the average or mean post-void residual urine. It increases with increasing age. This is just a generalization. Some people less, some people a little bit more. As a consequence, as you see that volume approaching with late life, 100 milliliters of retained urine, it sometimes gets a little confusing as to what's actually age-related and what might be pathologic, particularly when we do bladder scans. When we use the bladder scanner, the big problem is that the post-void residual urine tends to increase disproportionately in frail older adults, and that's because of what we call detrusor hyperactivity with impaired contractile function, DHIC for short. It's a situation where the muscles and the bladder are like a Charlie horse. They get spastic, but they don't contract real well, so they're sort of undulating. In medical understanding, it would be the equivalent to an atrial fibrillation of the heart, where the heart just can't get a firm squeeze. It flutters. We also need to think about lower urinary tract symptoms. A lot of times, people call them LUTs. These symptoms are associated with frequency nighttime urine hesitancy, slow flow of urine stream, and perhaps a feeling that you're not completely emptying your bladder. Overactive bladder is another term that's used with the complex of symptoms called frequency and nocturia. Overall, the incidence of urinary incontinence is quite extensive, and it's not necessarily an age-related phenomenon per se, although it increases, but it's estimated that 25% of women experience some form of urine leakage. As mentioned earlier, there's urge incontinence. That's where you have the strong urge to urinate despite the bladder not being totally full. We'll talk a little bit about how to address that in a therapeutic manner. Stress incontinence occurs when you laugh at a good joke, when lifting, a lot of times grocery shopping. It might occur with jumping and/or coughing, so there are different precipitants. It may be just simple walking that can cause stress incontinence. The mixed incontinence is a combination of both urge and stress. A lot of money is being spent on urinary incontinent products. The good news is that, despite this prevalence, there are approaches that can really either eliminate urinary incontinence or alternatively reduce the symptoms substantially. Urinary incontinence medications have anticholinergic effects, so if it's not making any difference in somebody's life, deprescribe it because of the medication burden. However, if it's reduced symptoms considerably, going to the bathroom 4 times a day rather than 10, keep the medication. Always look at the patient's medications to ask them if it's helping them in any way. That includes pain medications. Some of the opioid medications used for pain after long-term use actually increase the pain rather than decrease it. When somebody complains that they've been on long-term opioids and their pain is getting worse, that's more than likely a side effect of the medication. Again, we're always looking for side effects. Urinary incontinence is prevalent in the community. Up to around 25% of people have some form of urinary incontinence. That really skyrockets in long-term care, One of the major reasons why patients with Alzheimer's disease end up in a nursing home is because of urinary incontinence. When you have dementia, your sense of smell goes. A lot of times, people walk into a nursing home and it has that urine smell, and that's a little offensive to people. Those that are cognitively impaired can't smell it, so they're not suffering from odor malaise. That's an important consideration to educate patients and their family members about. Regrettably, women have urinary incontinence more than men. A lot of that is related to the pelvic anatomy and also compounded by childbirth. In terms of socioeconomic or racial differences, Caucasians tend to have more urinary incontinence than other races. The younger you are, you're most likely to have that mixed pattern of urge and stress, whereas with the old, you can remember the fibrillating bladder. It's usually associated with urge incontinence. The impact of urinary incontinence is pretty extensive. It can change social functioning, people who now don't want to get out. It reduces sense of well-being and your general view of your health. It could be viewed as an embarrassment, so it really does lower self-perception and can lead to additional social isolation and withdrawal, which are important considerations. The physical impact of urinary incontinence may include dermatitis, frank infections, cellulitis, worsening of either pressure ulcers or predisposing to pressure ulcers, particularly in the bedbound patient. Turning people every 2 hours is the standard of care for those that are bedbound, but not necessarily evidence-based. You can develop a pressure ulcer within 30 minutes, as much as you can develop a pressure ulcer within 2 hours. The other point of urinary incontinence is that it can predispose people to urinary tract infections. We'll talk a little bit about what constitutes a UTI. It can disrupt sleep. If you're going to the bathroom all night long, it's not so good. Sexual dysfunction can be a consequence of urinary incontinence. The risk factors are clearly age and obesity. High BMI probably even more so. Functional impairment. If you just can't get up and get to the bathroom, you're going to have accidents, such as stress or urge incontinence. Memory impairment predisposes to urinary incontinence medications. If you're on water pills, in particular diabetes and neuropathies associated with that potential barriers to toilet access, such as being on a long road trip, and also prostate issues for men. With diabetes, you get neurogenic problems. There's nerve damage. You get a bladder that's overactive because there's not a coordination of the nerves. There's a couple of classes of medications, such as thiaglitazone and gabapentin, that can cause peripheral EMA. That predisposes to urinary incontinence because when you lie down at night, you might have nocturia because the fluids get redistributed as a consequence of their accumulation during the day. Also, compounding urinary incontinence and diabetics is poor sugar control. The glycosuria, or the spillage of glucose into the urine. Constipation is a big issue, not only for diabetics, but somebody that hasn't had a bowel movement in 3 or 4 days. In this instance, it is called obstipation. That can be associated with a fecal concretion that pushes the bladder over and causes incontinence. Also, peripheral vascular disease, PVD, can cause ambulation problems and will restrict people from getting to the bathroom in time. The problem with dementia is that there's more urinary incontinence because of not always knowing when to go, and also with mobility limitations, it's the opposite issue. Dementia is often associated with people not remembering to drink enough water, and so they get dehydrated. There's a kind of a compounding factor here of fluid intake and bladder control. We know that the pathophysiology of urinary incontinence has an age-dependent component. Part of that is due to the bladder not being able to contract. We experience generalized muscle weakness as we get older, so too, we get bladder weakness, which is a muscle. We also get this regulation of the nervous energy that goes to the bladder, and so we get these uninhibited contractions. You really don't want the bladder to contract, but it's going to contract on its own anyways. A lot of it becomes mind over matter to try to get that bladder back into control. We're going to talk about ways to do that. And then also with age, we tend to have a diuresis later in the day than in the morning. There's also elements of reduced sphincter tone, so the urethral sphincter and the rectal sphincter tend to get more lax, and then the bladder capacity is activated at lower volumes. Lower volumes cause the bladder to start fibrillating. Evaluating urinary incontinence is a multifactorial approach. There's a lot of reasons for urinary incontinence. A lot of it is associated with multiple morbidities. You got a little diabetes, or you've got pre-diabetic, you're on diuretics, and so forth. It all starts to add up, so that includes the medication concerns, particularly medications that can cause peripheral edemas. The thones, the gabapentin, and also the second generation of calcium channel blockers, such as amlodipine, and a big one is somebody's functionality. Test for their gait speed. If somebody is walking less than a meter per second, we know that there's impaired functionality that we need to address. They may need to use a walker or have a nightlight in the house to navigate safely to the bathroom. In our evaluation, the recommendation from the American Geriatric Society and other incontinence societies suggests that we should ask women regardless of age annually if they have any form of urinary incontinence. Half of them will not reveal this in their clinical encounters. They will just assume that it's normal, and why bother the provider with that information? We want to be bothered with that information, so we encourage patients to reveal through structured questions. The screening questions could be: do you have any problems with bladder control? Can you make it to the bathroom on time? Do you ever leak urine? All of those questions are what we call icebreakers. Those can introduce the topic. Sometimes people are not always happy, or they're just reluctant to talk about urine incontinence, particularly if they have a family member there. If you get a positive response, do you ever have a leakage or you can't get to the bathroom in time? Start to break it down into: do you lose urine when you do physical activity, like when you're gardening or bending over coughing? That's stress incontinence. Urge incontinence is where you really got to go. Do you get to the bathroom fast enough? Mixed is when you say one or the other, and you try to establish whether it's a prominent stress or urge version. If you identify somebody that loses urine in the absence of either urgency or physical stress, start thinking about serious neurologic problems. And that's where we're getting into red flag symptomatology, a lot of times associated with spinal cord lesions from cancer or other conditions. When we evaluate urine incontinence, we want to establish: when did it start? Is it recent? Has it been going on for years? What's the frequency? Is it once or twice a day? All the time? Try to establish the volume. Is there a little spotting on underwear or the pad, or is it full? Figure out what makes it better or what makes it worse. Obviously, bending over, squatting, exercising, lifting things may make it worse. Other things may make it better, such as trying to hold your urine before you pee. That's actually a therapeutic intervention. What about fluid intake? How much caffeine are they drinking? Drinking a lot of caffeine will make you pee a lot. Caffeine is good for asthmatics because it's a vasodilator in the bronchiole. A lot of times, we tell these poor mothers with their asthmatic kids, if they ran out of some medication, give them a Coke. That used to be the old-fashioned methodology until we can get them into the emergency room. The Lutz symptoms are the frequency. All those other symptoms not CA, and so forth. Ask: do you use pads or any special garments? Try to understand what they've done in the past to help this. A lot of times they'll tell you about the medications they were taking for this. Think, too, about non-pharmacologic interventions. Lack of bowel movements are as important as loss of continence and bowel continence. Fecal incontinent plus urinary incontinent, that's a red flag. You need to have a little stronger understanding of the neurologic exam. When you have these red flag symptomatologies, you also want to ask about issues with depression, sleep apnea, or obstructive sleep apnea, which can also compound urinary incontinence. The red flags are abrupt onset of urinary incontinence. If you have any level of pain, back pain, or pelvic pain, that's an important consideration for a red flag. If you see blood in the urine that wasn't caused by beats, any neurologic findings like nuance, numbness, motor weakness, those are all red flags associated with urinary incontinence. The other question is, you want to ask how the urinary incontinence is affecting the patient's function. What troubles you? What bothers you most about it? How does the urine leakage affect your daily life? Try to understand the functionality. If somebody doesn't go out anymore, that lack of socialization is the equivalent to smoking 10 cigarettes a day in health impact. The cascade of urinary incontinence, social isolation, deterioration of health just goes right on down the line. It's important to look at medications. You want to look at the ACE inhibitors. 10% of them can cause a cough. If they cough all the time and lose urine, that may be the ACE inhibitor, and you should switch to an ARB. Calcium channel blockers can be associated with not only reduced bladder contractility, but also the second generation, such as amlodipine, can cause ankle edema. Ankle edema is usually prevented by preceding medications for high blood pressure with either an ACE or an ARB inhibitors. Diuretics can be associated with urinary incontinence. Opioids can cause urinary retention, and they can cause constipation and sedation, which may lead to further functional impairment. Anticholinergics, Tylenol PM or NyQuil, contains Benadryl and can lead to impaired emptying and urinary retention. At the physical exam, we want to establish the geriatric 4Ns with each clinical encounter. This should include the mini-cog. If they screen positive on the mini-cog, which is less than 2 minutes to do, it's 3-object recall, clock draw, and you're done. If that's positive, you want to go to the SLUMS test, which is a little bit more extensive and establishes the level. Is it severe, moderate, or mild? Cognitive impairment in terms of functional screening, you can do the timed up and go test. You can ask them to transfer from one place to another, or you can ask them how they're functioning with their activities of daily living. Finally, we've got the genital urinary exam. We'll walk you through a few of those components. One of the things that often gets overlooked is the digital rectal exam. Establish that the individual has anal sensation. Usually, when you do the external exam, you touch the rectal area and it should give a wink or a little squeeze. With the digital rectal exam, you also palpate for either fecal obstruction, mass, or impaction. Alternatively, you can look at the bubble cavernous reflex. That's where you either touch the clitoris or the glands of the penis, and you'll see the anal sphincter also create a wink. There's 2 ways to elicit the response, and you can see in the picture here that there's 2 different pathways by which that occurs. For the female exam, the most important part is just a direct observation of a cystatial, where you see part of the vaginal opening press outwards when the individual bears down. For the male exam, there's issues with an uncircumcised penis, where there's phimosis, a constricture of the foreskin. You can see the different gradations. The type 5 is probably the most serious because that can cause strangulation and gangrene of the penis. You can also get inflammation nonspecific, or you can get infections related, a lot of times associated with candidiasis, as you can see in the photograph there. Like cardiac stress tests, there are urinary stress tests. You have somebody drink a half to a full liter of water, they get a full bladder. You can document that on a bladder scan. Then you just observe them after they do a deep cough, and you see if there's any expression of urine as a result of that. Other testing that you might consider is to get a urine analysis. We're looking for blood in the urine and sugar spillage. If you have an elevated white blood cell count without bacteria in the urine, or if you just have bacteria without symptoms, those represent asymptomatic bacteriuria and not a urinary tract infection. Somebody has to complain of either having a fever or frequency dysuria pain with urination to really qualify for urinary tract infection. There are now recognized individuals that walk around with bacteria colonizing their bladders, and by treating them frequently, you end up getting drug resistance bacteria. You might actually accelerate the person's death because they might get C. diff colitis on top of a drug-resistant bacteria. We're just much more cautious these days about treating urinary tract tests. Urine analysis are not sufficient to say they've got a UTI. Without the symptoms, you don't treat. Some of the other tests that we can do is a bladder diary. You can see this from the National Incontinence Association. Try to identify the volume of lost urine and how much fluid intake. In the instance of doing a bladder scan, do the bladder scan in the office and/or refer them to ultrasound and radiology. They can do a pre and post. The post-void residual is particularly important in diabetics who may have a neuropathy if you've known that they've had urinary retention before, that a male has a prostatic serum antigen elevation, and then a few of the other points that are listed here. Urodynamics aren't done as much anymore. They identify when the bladder starts to fill and it starts getting into those undulating contractions. There might be some instances where your dynamic testing is done for special reasons that we talked about before. For treatment, it's most important to really establish the goals. Are we looking for a complete cure, or are we satisfied from the patient's perspective with a reduction in symptomatology? Is partial continence considered a goal that we want to achieve? Achieving the goal is both a reduction in frequency of the bladder symptomatologies and also a reducing the volume of lost urine. That's why you try to calculate how much urine is lost with each episode. Some of the treatment options that we look at are to eliminate contributive factors, such as first, not being able to get to the bathroom on time. Maybe they need to have a bedside commode or urine bottle. There's some lifestyle modifications we can talk about that include behavioral therapy. We'll talk a little bit about medications. There are some devices that are available that include things like pessaries for cystosols, and we'll talk about neural stimulation and surgery. Here's the happy weight loss person. You can see the lots of food in the beginning and more modified foods in late. Weight loss is one of the key and critical interventions. Weight loss is always replete with all these programs. The first 3 months you lose weight, and then the next 6 months you gain it all back again. It's going back and forth. For those that do lose weight and sustain that weight loss, it substantially reduces urinary incontinence. It's recommended to not drink any water after 4 p.m. or after dinner. No evening fluids. Less alcohol can also disrupt the diurnal rhythm and also contribute to weight gain. Caffeine reduction. Caffeine is a diuretic and certainly smoking cessation. There's behavioral therapy for the bladder. The University of California, San Francisco has a really neat website that brings out interventions for urinary incontinence. It is recommended to have a frequent and scheduled urination or micturition. A lot of times, you go every 2 hours, whether you need to go or not. That's called scheduled toileting. You can also do suppression. If you feel like you have to go, you just hold it and wait until it passes. There are also pelvic muscle exercises. Those are the famous Kegel exercises. Kegel exercises help improve the muscle, which is important for holding the urine. It's particularly helpful in post-prostatectomy for men. It's equally effective for both genders. In the beginning, you want to do what's called high intensity and low repetitions. You have that squeeze down on the perineum, hold it just for a couple of seconds, and you do those repetitively. Eventually, you try to build up to a count of 6 to 8 seconds. The recommendation is to do 3 sets daily. With medication considerations, you want to treat urge or the mixed, but not necessarily the stress. It's the urge incontinence that really gets the emphasis for the medications. There are antimuscarinic medications that are used for urge incontinence. Some people call that overactive bladder. If you have an urge heavily represented in the mixed urinary incontinence, then it's also amiable to antimuscarinics. They decrease the neurotransmitter acetylcholine, and it allows for an increased bladder capacity. The bladder is always trying to squeeze. You're trying to get it to relax a little bit before it starts squeezing. As you get older, the bladder increases the capacity. There are some people that benefit from it, and they get increased quality of life as a result of both antimuscarinic therapy and behavioral therapy. There's currently 6 medications that are available. There's no side-by-side analysis to say which one's better than the other. In those kinds of medications, the antimuscarinic side effects are something to consider. They're not particularly trivial. Although some of the medications are touted to have less side effects than others, don't believe it. There's cognitive impairment, so with short-term memory loss, you get also potential urinary retention. You actually make the condition worse, and now you've got an obstructive uropathy as opposed to an urge incontinence. If somebody has glaucoma, particularly for closed-angle glaucoma, not good. If somebody's diabetic, it could exacerbate their gastroparesis. And if somebody's already constipated, opioids are not a good medication to give. It also causes dry mouth. Mirabegron is an adrenergic agonist as opposed to muscarinic. That's just a different mechanism. You can see the chemical formula. They're one of the issues that it does have drug interactions with beta blockers. It can increase blood pressure. For the hypertensives, which 85% of older adults are hypertensive, it's not an ideal medication. Everybody uses duloxetine for everything. For fibromyalgia, you use it for gastrointestinal or reflux. Duloxetine is like the miracle drug, but it's off-label for urinary incontinence. The topical estrogens have mixed evidence as to whether they work or not, probably leaning towards people that remain sexually active in late life, that it might help build with the vaginal tissue. Its impact on urinary incontinence is mixed, and there's different options. There's gels and pills. There's even estrogen. People with pessaries can have estrogen-laced pesty. Compliance is an issue too. Patients don't always persist with using them. For surgery or other interventions, the minimally invasive ones are nerve stimulators. You can see a picture here of an internally placed or subcutaneous placed stimulator. They have external stimulators too, that either stimulate the tailbone area or the tibial nerve, which is on the back of the leg. Botox has been used. It has mixed reactions for its efficacy. The pessary is that donut-shaped object put intravaginally to address stress, as well as urge incontinence, but usually associated with lax pelvic musculature. Surgery is a colposcopy or colposuspension. There's a set of stitches that are used to lift the bladder up. Post-prostatectomy, there are artificial sphincters. There's a mixed bag as to whether they actually work or not. The other treatments are to use pads and incontinence garments. Here are our references. You can Google a lot of the stuff. The recommendations of medications by ChatGPT are totally incorrect. ChatGPT is 1 year behind on medical information. Thank you for listening to this presentation.